Welcome everyone to the infection specialty curriculum update. We're going to present to you the background to the changes to the curriculum assessment and implementation. Just one or two housekeeping points to inform you of. That your cameras, mics and chat function are all disabled. We won't be able to hear you speak. If you put your hand up, we won't be able to respond to it. However, your Q&A function remains active throughout the meeting, and you can submit questions throughout the meeting. We're expecting maybe up to an hour of presentations from the speakers, followed by up to an hour of Q&A. So we're hoping we'll have plenty of time for question and answers. The webinar is being recorded, although none of the participants will be visible other than the panelists. And subsequent to the meeting, the webinar will be available to view both on the RC Path and the GRC PTB websites. And the curricula and all of the supporting documents will be emailed to the participants subsequent to the webinar once they are all finalized, and those will also be available on both the websites. So if I can maybe move to the next slide. We have four speakers and a number of other panelists, and I thought I might just ask each panelist to introduce themselves. So myself first. I'm Ray Fox. I'm the ID Training Programme Director for the Scotland Deanery, and also I chair the Infectious Diseases and Tropical Medicine Specialty Advisory Committee and the Curriculum Development Group. So maybe if I can just go through each in turn. Bridget?
I'm Bridget Atkins. I'm a microbiology infectious disease consultant in Oxford. I chair the MedMicro Training Committee and co-chair the Combined Infection Training Committee and co-chair the Curriculum Development Committee. I'm demitting from these roles as we speak, but still remain very active at the moment.
Tanzina?
Hi, good morning. I'm Tanzina Haq. I'm a consultant in virology at Royal Free Hospital, London. I am a co-chair of the Microbiology Virology Specialty Training Committee for RCPAD, and also a member of our Infection Curriculum Development Working Group. Thank you.
Thank you. Alistair?
Hi. Morning, everybody. I'm Alistair Miller. I'm an infectious disease physician by background. I was previously chair of the SAC and very much involved in the infection training project for many years. I now work as Deputy Medical Director of the Joint Royal College of Physicians Training Board, where I chair the Curriculum Development Committee there, bringing all the different curricula for the 30 specialties that we manage. So very much involved in all the curricula, the physician curricula, but obviously with a particular interest in the infection project.
Thank you, Alistair. And Alec?
Hi, I'm Alec Bonington. I'm a consultant in infectious diseases in Manchester, and I'm the Training Programme Director for infectious diseases here, and the curriculum co-chair for infectious diseases for the Specialist Advisory Group.
And Julian?
Good morning. My name's Julian Sutton. I'm a consultant at Southampton in microbiology and infectious diseases, and until recently, Training Programme Director for Wessex Infection Training, and I've been on the Curriculum Development Working Group for a number of years.
And Zoe?
Hi, I'm Zoe Fleet. I'm the Curriculum Assessment Manager for the Joint Royal College of Physicians Training Board. So I've been working closely with Alistair and also with the RC Path on the development of the latest curricula.
And Jo?
Morning, my name's Jo Brinklow and I'm Director of Learning at the Royal College of Pathologists.
And Laura?
Good morning, I'm Laura Mauro and I'm the Training Officer at the Royal College of Pathologists.
And Jenny.
Hi everybody, I'm Jenny McGinley. I'm the Training Manager at the Royal College of Pathologists.
So a panel bristling with expertise on the topic of curriculum development, and I hope we can manage all your questions. So we'll move on to the first speaker, which will be Bridget.
Thank you, Ray, and thank you. I'm pleased to see we've got 72 attendees, which is great. Just one extra thing, the question and answer is a bit like Slido. So if you like a question that somebody else has posed, you can vote it upwards. So the one that gets the most votes goes to the top of the list. Okay, so I'm just going to give a very brief background about training infection. Sorry, next slide, please. It seemed to have muted itself. I don't know when I went muted. Hopefully only just now. So infectious disease training, just a very brief timeline. In the 1990s, we had infectious disease training and medical microbiology and virology training. Those were combined together in the 1990s as one speciality or one curriculum. Next slide. And then joint training, that means training of ID with med microbiology and virology, was approved in 1999, and I was, I predated that, but was sort of joined that brigade, and we've been training joint trainees, dual trainees ever since that time. And later, because of changes in the Part 2 exam, which the GMC wouldn't allow two different forms of an exam in one curriculum, the virology and microbiology curricula had to split from one CCT to two CCTs. Next slide. Then along came the combined infection training. The background was, and Alistair was involved very much at this stage, I know, is that the Academy of Royal Colleges recognised that lots of people were joining dually training in medical microbiology and infectious diseases, or medical virology and infectious diseases. So there was a proposal to have a single CCT in infection at that stage, to have pluripotential specialists who could do lab diagnosis and clinical management of patients with infections, and can also do infection prevention and control. So this was the intention of the Academy of Royal College of Physicians, Royal Colleges, and then there was a delivery group, and it ended up being what we now know as combined infection training. Not quite as this statement intends, but it's what we're now used to. Next slide, Laura. Which is combined infection training. So the GMC approved combined infection training in 2014, and that led to the requirement for general medical training prior to coming into this speciality. It's previously not required for the monospecialty trainees in microbiology and virology. And then application entry into the first 2 years of training, which is combined infection training, which led automatically onto a further 2 years of higher specialty training. That was the term at the time. And if you're dual trainees, then you need 3 years of higher specialty training. So that's the place where we were in 2014. And that change meant actually we were well ahead, as a specialty, we were well ahead of the curve in terms of shape of training. So next slide, please, Laura. So the shape of training report was published in October 13. And this was the webpage for the shape of training report. And many of you will have seen this. Next slide, please. And the principles of the shape of training were very much what we'd already done in 2014 with combined infection training, which is to produce more generally trained consultants who could change their role if needed according to the requirements of the employer and the patient population, and can have a much greater role in emergency and acute care and in continuity of care, and also to get involved with care in the community. And there's many examples of how this has been strengthened with combined infection training. And we also it's been quite clear that the quality of trainees coming into the specialities has increased a lot since combined infection training came in. Next slide, please. So because of the shape of training recommendations, there's been a lot of work already done on internal medicine training prior to going into speciality training. And stage 1 training, which was previously core medical training, has been changed to internal medicine training, IMT stage 1, and that changed in August 2019. So those people will come to the end of 2 years in end of July this year. It's actually a 3-year structured program with increased training in geriatric medicine, critical care and outpatients as part of that program, which is more than the CMT trainees did in the past. Program of assessment in some ways similar to what we're going to describe today for speciality training. Next slide. So then regarding speciality training, the physicianry specialties were then split into 2 groups, which follow 2 different training pathways. A lot of discussion about the complexity of the infection specialties and which groups they should be part of. So essentially the group 1 specialties would need to do 3 years of IMT. So the 3rd year is effectively a medical registrar job. And then they must dual train with internal medicine. A lot of the specialities, the majority of the specialities in the physicianry specialities are actually group 1 specialities. And by far the vast majority of numbers of trainees are in the group 1 specialities. So now, for example, neurology will need 3 years in order to enter, and will require to do general medicine in parallel, with the aim of producing more people for front door medicine care. Group 2 specialities will require only 2 years of internal medicine and will not dual train with internal medicine. And there's a number of generally smaller specialities which are group 2 specialities. Next page. So the group 1 specialities in infection, which will start in August 2022, and Ray will talk more about the transition, are the infectious diseases in internal medicine will be a dual CCT, which will be a group 1 pathway, and tropical medicine, internal medicine will also be a dual CCT. So these, in order to enter these specialties, 3 years of IMT will be required, and they will have to train in parallel with internal medicine during speciality training. Next slide. So this is the pathway for infectious diseases and internal medicine. So you do your foundation years as now. You're selected into a 3-year internal medicine stage 1 program, and during which time you will get your MRCP. Then as now, there'll be national recruitment, and there'll be a selection into combined infection training with internal medicine, and that will be a total of 4 years of training. So 2 years of combined infection training. Total duration unchanged from previously, and at the end of that time you'll get a CCT. Next slide. The group 2 pathways in infection specialities, which will start from this year for new starters, medical microbiology as a single CCT, medical virology as a single CCT, ID Med Micro as a dual CCT, ID Med Virology as a dual CCT, and then tropical medicine with medical microbiology or medical virology as a dual CCT. There's actually no change in durations of any part of the pathway in these group 2 specialties from previously. Next slide, please. So for the monospecialty trainees, medical microbiology or medical virology, no change to what we currently have in terms of indicative durations. So there'll be foundation training, 2 years, selection into 2 years of internal medicine. Trainees, there's nothing to stop trainees doing that third year medical registrar job if they wish to, but it's not a requirement. But they'll still, if they do that year, still be eligible to go for Group 2 specialities. It won't rule them out in any way. Then they'll be selected then by applying at national recruitment in the same way as currently into combined infection training, which will be still 2 years, and then they'll have 2 years of medical microbiology or medical virology higher infection training. We've changed that term to make it clearer that the bit that follows combined infection training is now called HIT or higher infection training. As before, you'll get your MRCP during your internal medicine stage 1 training, and then there'll be a requirement to get FRC PAF during specialty training, both parts. Next slide, please. This is for the dual trainees. So similarly, foundation training, selection into IM training. Again, 2 years is the eligibility criteria to get into combined infection training with this pathway. And again, if trainees wish to do a third year, that's not going to penalise them in any way. They'll be selected into combined infection training at that stage, and then they'll have 3 years of medical microbiology or medical virology training with infectious diseases and to pass the exam. So no difference at all to what we currently have. And at the end of that time, obviously they get a CCT. Next slide, please. Next slide, please. Julian and Alec will talk more about this, but the changes, the actual content of learning or the syllabus has not really changed. So the experience will be the same. The biggest change is within the assessment of trainees. And so there'll be a small number of higher level learning outcomes called CiPs, which will replace the larger number of competencies that we currently have. So the aim has been to make it more realistic and more manageable. That'll be a more holistic assessment of trainee progression. There'll be the judgment of the educational supervisor, which will be entirely based on evidence presented to them by clinical supervisors and using entrustment levels, which we'll come on to. And then we will show you a progression grid which sets out the expected level of entrustment at each training year. And we can talk about critical progression points, which are essentially just into the training program and out of the training program. Generic and specialty CiPs have been mapped to the GPC, the GMC's generic professional capabilities, which we'll outline more in a minute. Next slide, please. So in summary of changes, we'd already done most of it with the 2014 curriculum, so we delivered most of the priorities. So the content has not massively changed. We've strengthened some bits of the curriculum. So we've strengthened infection control for infectious diseases trainees, for example, and we've strengthened pediatric training and some of the small print as well in terms of the curriculum, but in terms of the syllabus, but no major changes to content. So there shouldn't be any major requirements on training programs to change how they currently deliver training. We have split the infection specialties into Group 1 and Group 2 specialties. So infectious diseases cannot be trained in as a single CCT. It has to either train with internal medicine or with medical microbiology or with medical virology. That cannot be a single CCT. High-level outcomes have been introduced, and there have been some changes to the medical microbiology Part 2 exam, which we're not planning to cover today, but can be answered in questions if required. Next slide, please. I think this is my final slide. There's been a lot of work, and I have to say that the college staff have been fantastic in this and have worked extremely hard on helping to deliver and to nag most of us to do what's needed. It's been a lot of work for everybody. There was an infection specialty curriculum development group. That group is not completely represented on this panel. So we had trainee members as well, and other representatives, not necessarily here today. So it represented all of the infection curricula, we had tropical medicine representation as well. That we then had to put the curriculum through the curriculum oversight group to ensure that this was providing what the general public needs and applied the shape of training principles, and it all made sense. And then it had to go to a curriculum advisory group. And then we've had to move on to implementation and delivery of the new curricula, which is what we've done is produce a rough guide, which we'll share with you very shortly, decision aids for each of the different combinations of training. And then we've had to make changes to the ePortfolio. And now we're onto an education process of trainers and trainees and sharing of information. Next slide, please. I think that's the end of my talk. I'm here for questions at the end, obviously, or you can pose questions as we go, but we're proposing to take questions, all the questions at the end rather than now, I think, Ray, aren't we?
Yes, thank you, Bridget. Yeah, just to remind everyone that you can submit your questions throughout the webinar, and we will we'll try and collate them all at the end and address all the questions subsequent to the presentation. So I would encourage you to do that. So now Julian and Alec are going to present on the CiPs and the entrustment levels in more detail. And these really are the key major changes that are taking place. As Bridget says, that the actual content of the curricula and the delivery of the training is much the same, but it's how we assess progress that is the major change. So I think, can I invite Julian? I think you're going to go first.
Thank you very much, Bridget and Ray. So yes, Alec and I, for the next 10 minutes or so, we're going to talk about capabilities in practice, entrustment levels and decision aids. If I could have the next slide, please, Laura. So this is just a reminder for me to mention that 4 years ago, the GMC undertook a major piece of work which basically was in headline to address the issue that specialty curricula across the nation didn't really have anything hard and fast about all the generic professional capabilities that any doctor who either is in training or practicing should adhere to certain standards. So if we have the next half of the slide, so things like professional knowledge, obviously important, professional values and behaviors. But if I pick out a couple of those cells around the edge there, so every single doctor in training across the 4 nations should be adhering to a certain level of patient safety and quality improvement. For example, they'll be demonstrating leadership and team working as part of their training and delivery of care. They'll be involved in education and training. So one big change is that these generic professional capabilities are now mapped to all the specialty specific new curricula across all of the 4 nations. So this has been a nationwide process of updating, revising all curricula in line with this GPC framework, but also very importantly, the capability in practice framework. Next page, please. So this is just, and if we could have the anchor statement on the right, this is again a reminder for me to say that whilst the content of the curriculum and the syllabus, as Ray has pointed out, essentially hasn't changed at all, and as Bridget has pointed out, we've actually strengthened it a little bit in certain areas. It's this concept of entrustable professional activities, which is a high-level judgment, if you like, by an appropriately qualified clinical or educational supervisor about how a trainee, what level of supervision essentially they require and are safe in delivering patient care in a particular high-level piece of clinical work. And that could be something pretty high level, like running a medical tape, for instance. But it's this concept of entrustable professional activities that is a new way of the anchor statement, which as well as capability in practice essentially replaces the word competencies. Next slide, please. So I'm just going to say a quick few words before I pick out a few of these points on this slide. I had a quick look this morning about the first draft of the capabilities in practice for infection that Alec and I wrote, and it was early 2017. So you can see that this has been a long time in gestation. I will point out when we get to them, you'll notice that the 7 infection SIPs and the 1 tropical medicine specific SIP, they don't actually mention specific infectious conditions or syndromes, but we've worked very hard to ensure that between them, that they cover all aspects of the care and knowledge and skills and capabilities that a trainee would need to gain to CCT in the relevant specialties. So I'll come on to the individual SIPs in a minute, but just to pick out a couple of points from this, that they are high level activities and areas of knowledge and practice that a suitably qualified clinical or educational supervisor should be able to make a pretty high level global judgment about the level of capability of a trainee in. And in order to complete training, the doctor must demonstrate that they're capable of unsupervised practice in appropriate SIPs. So that's part of the curriculum attainment level to gain your CCT, that in virtually all SIPs, with certain notable exceptions, trainees will be entrusted to act unsupervised at level 4, and Alec will go into this a little bit more, within that broad area that's described by the particular capability in practice. Next page. So I'm not going to dwell on the next 2 slides too long, but this is just to say that whilst the number of SIPs for specialties has been mandated to be small and is typically between 7 and 10, and for infection, if you count the tropical medicine SIP, is 8, so that's only 8 capabilities in practice, whilst they're very high level in their overall span, there are lots of examples, and if you look on the right-hand side of the slide here, what we call descriptors. Now, I want to be clear that these are not proscriptive definite requirements, but they are a list of examples of the type of activity and knowledge and skills that a trainee would display in particular areas, including the mention of certain infectious conditions and syndromes. I wouldn't get too bound up in the generic professional capabilities, the GMC capabilities that I mentioned in my first slide, but it's just to say that every aspect of the new infection curriculum is mapped to certain GPCs. But I don't think actually, I think it's good that they're included, but it doesn't really alter the way that we deliver training and supervise our trainees and ensure safe care. I think what is helpful is the evidence to inform the decision about capabilities within a SIP. And you can see that there are a list of work-based assessments down there on the bottom, including MCR, multi-source feedback, patient survey, CBDs, etc. And they are a list of examples of the type of assessment that trainers can use to make a judgment on the entrustment level within a certain SIP, a capability in practice. Next page, please. So just to reiterate then, each SIP has a set of descriptors associated with these activities, and they're not a comprehensive list, they're examples. But look again at the evidence to inform decision down at the bottom, the various assessments that can be used and are mapped into the curriculum to give trainers and trainees a really good opportunity, I think, to see exactly how they can evidence their level of entrustment. Next slide, please. So I'm going to be very quick on this one, but this is again a reminder that the GMC, independent of all the specialty curricula across the country, undertook a piece of work to develop generic SIPs, which are common to all doctors. And I'm not going to read through all of these, but if we pick out generic SIP 2, able to deal with ethical and legal issues related to clinical practice. If you just glance down that page, and you can look back at your leisure, these are all activities, level of knowledge and behaviours that all trainees and all doctors should be undertaking to a certain standard. So these generic SIPs are now actually referred to and mapped to all the specialty curricula. Thank you. Next slide. So I am going to dwell on this slide just for a couple of minutes before handing over to Alec. So this is the part of the meat of the change in the new infection curricula, the 8 infection specialty SIPs, capabilities and practice. And you'll notice that there, with the exception of tropical medicine, for which the eighth SIP is unique, the same 7 infection SIPs apply to all aspects of infection training. So whether that be med micro, med virology and infectious diseases. And I'm just going to quickly whiz through the 7 SIPs and then mention the Trop Med one at the bottom. So The first two specialty infection SIPs refer to, in part, use and leadership and appropriate utilisation of diagnostic infection laboratories. So providing clinical leadership and support to the laboratory and using laboratory services effectively in the investigation, diagnosis and management of infection. That's pretty much a taken and a given, and trainees need to develop independent, safe and trustable practice to an unsupervised level in those areas by the time that they are ready for their CCT. The third specialty SIP, able to advise on infection prevention, control and immunisation. None of us will need reminding about the importance of infection control and infection prevention at the moment. So that's a very strong and maintains a strong element within the curriculum. And that applies to infectious diseases as well as med viro and med micro trainees. So able to manage and advise on important clinical syndromes where infection is in the differential diagnosis. Again, if you think about that at high level, that really needs to apply to medical microbiology, med virology, and infectious diseases trainees. We're often managing patients where there's diagnostic uncertainty, and actually the final diagnosis may not be infection, but that's a very important part of our practice. Specialty SIP 5, able to lead and advise on treatment with and stewardship of antimicrobials. Again, I won't need to remind anyone in this audience of the importance of antimicrobial stewardship as we move forward, and the need to use our current antimicrobials prudently and appropriately so that they're preserved as far as possible. Finally, the specialty SIP, infection SIP 6 and 7, able to provide continuity of care to inpatients and outpatients with suspected or proven infection. So that's really the end-to-end care that would apply in particular to infectious disease trainees who should actually be able to manage a patient with suspected or known infection right from the front door through to discharge and then follow up in outpatients. SIP 7 refers to being able to manage and advise on imported infections, many of which we've seen a little bit less for understandable reasons over the last couple of years, but will remain an important part of the curriculum. And then finally, the final SIP, number 8, which I referred to, is specific to tropical medicine. So the tropical medicine curricula encompasses the entire infectious diseases curricula, but has an additional year, and the Trop Med specific SIP is able to deliver equitable and high quality care in a resource poor settings. Thank you. Next slide. So I'm now going to hand over to my colleague, Alec.
Thank you very much, Julian. So I'm going to talk to you a little bit about the assessment of these SIPs, and the assessment of the generic SIPs and the specialty SIPs is slightly different. So the generic SIPs, excuse me, that Julian has spoken about are assessed using these global anchor statements, and you'll be familiar with these because we've been using them in the ePortfolio for some time. But trainees will be assessed as below expectations, meeting expectations, or above expectations for this year of training for the generic SIPs. Next slide, please. For the specialty SIPs, again, as already mentioned, the SIPs are based on entrustable professional activities. And so we assign an entrustment level, and the educational supervisor, when he writes his report, will assess the trainee using these entrustment levels. And there are 4 entrustment levels, as you can see. So level 1 is where you're entrusted to observe only. Level 2 is entrusted to act with direct supervision, which means that you'll need a consultant on site with you, not necessarily in the same room, but who can rapidly come and assist you if needed. Level 3, when you reach level 3, you're entrusted to act with indirect supervision. That means that for that particular capability, you're entrusted to act where you will be delivering care within the hospital, but the consultant will be available outside of the hospital on the end of a phone. And then level 4 is where you're entrusted to act completely unsupervised. And for most of the SIPs, that's where that's the sort of level that you would get to before you get your CCT, but it's not, you don't need to achieve level 4 for every SIP, depending on which curriculum you're doing. So this grid that we've shown you here shows the first 2 years of combined infection training, and those 2 years are the same, whichever infection curriculum you're pursuing. The next two show a trainee who is training in medical microbiology alone, and so the entrustment levels on here are what you would expect to achieve in years 3 and year 4. And for medical microbiology alone, at the end of year 4, you would get a CCT. And you can see that for some of the SIPs, you don't need to reach an entrustment level of 4. And then the 3 columns on the right in green are for a trainee pursuing medical microbiology with infectious disease dual CCT, and again there's a grid outlining what entrustment levels you're expected to achieve at different points in your training, and the educational supervisor will be expected to assess these and document these each year when they do their educational supervisor report. Next slide, please. So as before, most of you will be familiar with the ARCP decision aids, and the decision aids are really there to guide the trainers and the trainees so that they know what they need to achieve a satisfactory ARCP outcome at the end of each training year. We are providing ARCP decision aids. There will be 5 different decision aids provided for the different combinations. So there will be one for medical microbiology or medical virology training alone, one for medical microbiology or medical virology with infectious diseases, one for medical microbiology or virology with tropical medicine, and then there will be one for infectious diseases with internal medicine and one for tropical medicine with internal medicine. So there will be 5 different decision aids, again, to make it clear for the different trainees in on the different training pathways as to exactly what will be required. One of the new things on these decision aids will be that the grid that I've just shown you, there will be a grid setting out the entrustment levels that trainees are expected to achieve for the specialty SIPs. In addition to the things that you're used to, which is the indicative number of structured learning events or workplace-based assessments that are required. And the educational supervisor report, as always, will be the key document to inform the ARCP of the trainee's progress. Next slide, please. So most of you are probably familiar with writing educational supervisors reports, and the key thing is that they're written ahead of the ARCP. So usually they're done in the few weeks prior to the ARCP, where the educational supervisor sits down with the trainee and they, they discuss the training of that trainee and where they're up to. And the educational supervisor report is completed. The educational supervisor will document the entrustment decisions made for all SIPs at this point. So this will be on the ePortfolio for the ARCP. It's recommended that if you're a dual trainee, that you should have an educational supervisor report completed by a trainer with a CCT in both specialties. So, for instance, if you're an ID medical microbiology trainee, if your educational supervisor is trained in both of those specialties, they can provide an educational supervisor report for both parts of that. But if your educational supervisor for infectious diseases isn't trained in microbiology, it would be recommended that the infectious disease ES provides a report for the infectious diseases side, and then ideally you have a separate supervisor who is then a medical microbiologist who writes an ES report for that side of things. Now, that's not mandated, and so if you have an infectious diseases only educational supervisor and you're an IDMM trainee, the IDES can provide an educational report for both sides, but they must then take particular care to ensure that they obtain detailed feedback from clinical supervisors who specialize in that other specialty. And as I say, the recommendation would be that you'd have an ES completed by a trainer with a CCT in the specialty that's being assessed. So thank you very much. I think that's the end of my bit, and I'll hand over to Ray, who's going to talk about the implementation of the curriculum.
Yeah, thank you, Alec. So yeah, I will just present a few slides around the implementation, transition and transfer to the new curricula. First slide, please. So as Bridget mentioned, the new starts to the Group 2 pathways beginning in August 2021. So this year will follow the new curricula from the outset. So if you have any new starts coming to your programs this August, they will follow the new curriculum. From August 2022, all new starts on Group 1 pathways will follow the new curriculum. And that is essentially trainees in ID internal medicine or tropical medicine internal medicine. As you know, there's been no recruitment to ID internal medicine this year to take account of the first year of IM3. So all new starts this August follow the new curriculum, and in ID Med Micro, and all new starts to ID IM from August 22 follow the new curriculum. Next slide, please. With regards to current trainees, and this is an important slide just to inform you of which trainees transfer and when. So essentially all your current trainees, except those in their final year, will transfer to the new curriculum in August 2022. So next year, the decision to transfer and its timing will essentially be confirmed at the next ARCP. So whether that's a cycle that has an ARCP in early 2022 or in the summer of 2022, that's when the transfer to the new curriculum will be confirmed. The final year of training, trainees in their final year of training, they will remain on the current curriculum until they've completed training and apply for their CCT. And for our specialty trainees, the final year of training is defined for both full-time and less than full-time trainees as a CCT date on or before the 31st of August 2023. So come August 2022, if your trainee is entering their final year of training with a CCT date on or before the 31st of August 2023, they will remain on the current curriculum. All other trainees will transfer to the new curriculum. The expectation then being that the vast majority of our trainees will be following the new curriculum from August 2023. Out of program trainees who return to program between this August and July 2022, they will transfer in August 2022. So when they return to the program, they won't transfer immediately, but in August 2022, again, unless they're in their final year of training. There will be some flexibility with regards to the transfer in some circumstances. So for instance, an example might be a trainee who goes on mat leave between August 2022 and July 2023, and they're in their final year of training. They then return to training subsequent to August 2023 to their final year of training. And so that might be an example of a trainee who would remain on the old curriculum beyond August 2023. And that should be discussed with the training program director and possibly with the relevant SAC. And there'll be some flexibility with regards to the timing. So, you know, if it just so happens that a trainee's CCT date is the 2nd of September 2023, then they would count as being in their final year of training. Next slide, please. The other important document that we have developed is what we've called a rough guide to the implementation of the new curriculum, which is in its final draft form currently, and will be imminently available on the RC Path and GRC PTB websites. We will also email the rough guide and the ARCP decision aids to all of today's participants. But it's an important document for both trainers and trainees to refer to with regards to the transition to the new curriculum, the planning of the trainees' training year, preparation for the ARCP, and guidance on the CiPs and entrustment levels. And all of these documents will be available on GRC PTB and RC Path websites imminently. Next slide, please. With regards to the ePortfolio, I'm not directly involved in the development of the ePortfolio, but I'm reliably informed that it will be fit for purpose come August. Trainees will continue to link evidence to the ePortfolio, to the curriculum on the ePortfolio, but they will not be required to re-link existing evidence to the new curriculum. The old curricula and the linked evidence will remain available to view but by the ES and the trainee. As mentioned, the educational supervisors report will be used to record the entrustment levels for the CiPs, and it will be informed particularly by multi-consultant reports, who will also be asked to feedback on the trainees' progress against the CiPs. Next slide, please. With regards to ePortfolio development, there will be a bespoke ES report form. There will be help with assessing a trainee's transfer to the new curriculum with regards to their current entrustment levels and what would be required of them to achieve the required entrustment levels by the next ARCP, and there'll be a summary of progress page. Next slide, please. Today is part of the training the trainers. So as training program directors, ensure that your supervisors are familiar with the new curricula and with the rough guide to implementation. As mentioned, all of these resources will be available on both websites. And so far as induction for new trainees, so these are the starts for this August, who will be following the new curriculum. There's an RC Path hosted new trainee welcome day on the 20th of August. So we would encourage you to ensure that all of your new trainees are able to join that. There will be a induction webinar similar to what we're doing today, but directed at existing trainees in early 2022. So those are the trainees who will transfer to the new curriculum from August of next year. So we'll have a webinar for them, and the new curricula will all be available on ePortfolio from this August.